Hello, everyone. I hope you enjoyed this second Lunch and Learn and find it interesting. If you do, shoot me a quick email and let me know what you thought. Today, we're going to talk about autoimmune encephalopathies. Now, our understanding of autoimmune encephalopathies has grown exponentially over the last 10 years. Patients used to come in as encephalitis not yet diagnosed with no potential treatments, but now we have the technology to identify which antibodies are causing the problems. And by providing immunotherapy, that is, by suppressing the immune system and telling the body to stop producing these problematic antibodies, we can help reverse the course of the disease for our patients. Now, for all autoimmune encephalopathies, the body is producing antibodies, represented in this picture by a red X, and that is interfering with the cell surface and the neuron or some of the synaptic proteins, and it affects the ability to conduct nerve impulses. These diseases seem to affect children and young adults more than the elderly, and patients do respond pretty well to immunotherapy, like IVIG, steroids, plasma exchange, rituximab, or cyclophosphamide. About 70 to 80% experience substantial or complete recovery. Now, in general, the symptoms develop rapidly, starting with a headache and mild hyperthermia. This evolves into alterations of mood, behavior, decreased level of consciousness, and often seizure activity. Now, when neurology works up these patients, they find an abnormal EEG, increased flare signal of the temporal lobes on MRI, and increased protein and lymphocytic pleocytosis in the CSF. Remember, CSF doesn't usually have protein in it, and if protein ends up in the CSF, it's a sign that the blood-brain barrier isn't working properly, and it's more permeable than usual. The brain's more irritated, but this is a really non-specific sign. It could happen with almost anything that we see here on neuro. Here's a list of a bunch of different types of autoimmune encephalopathies. We've seen Hashimoto's encephalopathy on the unit. We've seen non-vasculitic autoimmune inflammatory myelopathies, but we're going to focus mostly on anti-NMDA receptor encephalitis and limbic encephalitis. So the NMDA receptor is that little orange one on your screen. And the way this little receptor opens and closes is really complex, and it requires both of those little ligands to activate. These receptors are little proteins that control the electrical impulses in the brain, and their function is really critical for judgment, a person's perception of reality, human interaction, the formation and retrieval of memory, and then those scary autonomic functions like breathing, swallowing, blood pressure, etc. When they dysfunction, we see associated excitotoxicity that leads to nerve cell death, and we see similar symptoms as schizophrenia, epilepsy, and dementia. The activity of NMDA receptors is affected by lots of psychoactive drugs like PCP and ATOH. And in the case of anti-NMDA receptor encephalitis, the body is producing antibodies, shown here by those little red X's, and they attack this specific receptor, and this receptor itself can't do its job anymore. Anti-NMDA occurs predominantly in young women, about 80% of the time. Teratomas play a role in this disease. Most tumors associated with anti-NMDA are teratomas. It's those really gross tumors that grow teeth and nails and hair and stuff, and it actually starts to grow neural tissue. So that's tissue that contains cells identical to what's found in your brain, and that neural tissue in the tumor has NMDA receptors. So researchers think antibodies are initially formed against NMDA receptors because the body is trying to get rid of that tumor. And then it keeps on attacking those similar looking receptors that are in the brain, and we see the signs and symptoms of anti-NMDA receptor encephalitis. With this disease, we see inflammation of the brain, which is why we call it that brain on fire, particularly in the hippocampus, the amygdala, and the cortex, because the antibodies are attacking those NMDA receptors. So in a series of 577 patients, 81% were female, and the median age was 21 years old. 38% of patients did have underlying tumors, and of that, 94 of them. Approximately 70% of patients develop prodromal symptoms such as headache or fever that are usually followed by rapid change of behavior that might include anxiety, agitation, insomnia, aggression, visual or auditory hallucinations, paranoia, hyperreligiosity, sexual disinhibition, mania, psychosis, or catatonia. You can see why these patients would often be admitted to the psych unit to start off with, especially with it being young women that are kind of overlapping with when people normally have their first schizophrenic episode. These symptoms are usually followed by a wide range of abnormal movements. They might include orofacial dyskinesias, chorea, rigidity, or opisthotonus. That's a crazy spasm of the muscles, causing backwards arching of the head, neck, and spine. As the symptoms progress, there is decreased level of consciousness, coma, and then maybe some periods of agitation alternating with catatonia. Then we start to see some autonomic dysregulation like fluctuation of blood pressure, hyperthermia, excessive drooling, tachycardia, hypoventilation, and less frequently these patients go bradycardic or have ictal asystole, which means after they have a seizure or during the seizure they experience asystole and they might actually need a pacemaker inserted. Seizures and status epilepticus can occur at any stage of the disease, but almost always resolves after the other symptoms improve. I read a crazy case study where a 33-year-old female went as far as being comatose in ICU, no response to verbal or noxious stimuli, with intact brainstem reflexes and involuntary orofacial and upper extremity movements. She experienced something called autonomic storming, which was managed on continuous infusions of Versed and ketamine, which really didn't work. She could not be weaned from the ventilator, as evidenced by tachypnea and low tidal volumes when they tried to do breathing trials. And her oral secretions were substantial and really tough to manage. They would drip onto her subclavian line, thus compromising it. So what the nurses did is they used a subglottal suction catheter below her trach, and they would collect between 500 and 1,000 mils of saliva every day. She required a cooling blanket to manage her hypothermia up to 42 degrees. She needed IV acetaminophen. And during these crazy storming episodes, she frequently bit her tongue or her lips repeatedly. She would flex her neck so significantly it would occlude her airway, and she would violently flail her upper and lower extremities, disconnecting herself from the vent. She was in ICU in this state for 10 months. The immunotherapies caused neutropenia and colitis, so she was put on TPN. And even though they were able to get those antibodies down to about 75% of their original levels, there was no improvement in her level of consciousness. And unfortunately, she experienced a hemorrhagic cystitis, probably caused by the cyclophosphamide. That's the medication where we give mesna as well to try and protect the bladder. So her bladder ruptured into her peritoneum. She went into cardiac arrest. She required multiple washout surgeries and she was on vasopressors until her family elected to withdraw treatment. So the average length of stay for a patient in the hospital is 3 months and they often require tertiary rehab. This is because once those acute symptoms have resolved, patients still struggle with memory and attention deficits, impulsivity, behavioral disinhibition, and problems with their executive function. They basically have an acquired brain injury, so would need the care of nurses on places like Unit 58. The mortality rate of anti-NMDA receptor encephalitis is about 7%. So as a kind of summary, the patients start in a prodrome phase like I first described, and then move on to that agitation, seizures, and abnormal movement phase. If they are not responding well to therapy, then they clinically worsen to the comatose state, and they have those huge autonomic issues like we talked about on the previous slide. And if the treatment finally takes effect, they progress backwards through the agitation phase and then need neuro rehab to maybe return to baseline. So, about 50% of patients respond to those first line therapies, and then the other patients move on to rituximab or cyclophosphamide. About 20% of cases can relapse, so some physicians are choosing to use rituximab earlier, as these patients tend to have fewer relapses. Plasma exchange might be less effective in anti-NMDA receptor encephalitis because the antibodies are actually being produced in the intrathecal space. This is why plasma exchange might work better for those antibody mediated diseases of the peripheral nervous system, like myasthenia gravis, compared to the central nervous system. Trying to clean antibodies out of that blood brain barrier is pretty tricky. So, the physician that discovered anti NMDA, Dr. Dalmo, recommends removing or continuing some type of immunosuppression for at least 1 year after initial therapies are discontinued, since there is that 20 to 25% chance of a relapse. So here is another case study. On the eve of her high school graduation, a healthy 18-year-old female experienced new onset seizures, and less than 2 weeks later, she was in intensive care in a catatonic state. For a few weeks before her seizures, she experienced frequent and abrupt mood swings. They alternated between feeling super excited about graduation and lashing out at her family. She would wander around the house saying everyone is going to die, and then developed facial twitches and intermittent slurred speech. Her emotions fluctuated between extreme happiness and uncontrolled laughter to agitation with aggression and hostility. After admission to hospital, her GCS dropped to 9 and she showed other signs of mental worsening, including repetitive upper extremity movements, vocal tics, and facial dystonia. She remained in ICU for 5 weeks in that stage of scary autonomic instability with cardiac arrhythmias, blood pressure changes, hypoventilation requiring positive pressure ventilation, and desaturation episodes related to some breath holding spells. She also had hyperthermia and seizure activity. When she was finally diagnosed with anti-NMDA, she received a 5-day course of IVIG, as well as high-dose steroids and apheresis for 5 days, and they never did actually find an underlying neoplasm with her. She experienced refractory seizures, which were eventually controlled with lacosamide, and she alternated between periods of catatonia and agitation mostly in the evenings requiring olanzapine and clonidine. She really only minimally improved after a month in ICU, so she got rituximab weekly, and she was unable to maintain that adequate caloric intake or hydration when she was catatonic. So a G tube was inserted, which became a huge source of agitation for her. Her long recovery was not always clinically obvious, but it was revealed slowly through her artwork. So she was in rehab for 58 days when she started to draw the sounds that she was hearing. Her drawings became her principal method of expression and communication, and they started to improve in both subject and sophistication as she slowly emerged from the fog of her encephalitis. She experienced inappropriate behaviors during her inpatient therapies, such as hypersexuality, impulsivity, and hyperphagia. She was in hospital for 4 months and she'd finally regained some of her physical strength. She gained a voracious appetite. She was medically stable now, but she was far away from her cognitive baseline. We'll move on now to something called limbic encephalitis. This more frequently affects middle-aged or elderly patients and males on a 2-to-1 ratio. Usually it's one of 3 antibodies that are attacking these specific receptors. There's anti-LGI1, which we'll get to later, anti-GABA BR, and anti-AMPAR. The AMPAR was actually on that little animation slide beside the anti-NMDA receptor. So just remember the antibodies are just attacking a different receptor. These patients present with short-term memory deficits, confusion, and frequent seizures, as well as hyponatremia and myoclonic-like jerk. They're actually called facial-brachial dystonic seizures, and you're going to see an example next. So this 71-year-old woman presented with a 6-week history of progressive involuntary right arm and face jerking movements associated with prominent memory loss and frequent falls. Her MoCA score was 19. There was no alteration in her level of consciousness. Her MRI showed a bit of hyperintensity in the hippocampal region of her left medial temporal lobe. In her CSF and her serum, they found anti-LGI1 antibodies. They did a perineoplastic workup to see if a cancer was causing her body to produce these antibodies, but that was negative. She received pulse steroids, IVIG, and she responded rapidly. These spells stopped in about 2 weeks. Her memory improved over 2 months and her function gradually returned to baseline. though she had complete amnesia to anything around her illness or 2 months before her admission to hospital. Her MoCA score plateaued at 27 out of 30, and she discontinued IVIG after 2 months and was on a gradual steroid taper. The discovery of autoimmune encephalopathies has changed the paradigm in the diagnosis and treatment of all these disorders that used to be completely misdiagnosed. They could have been called schizophrenia, or back in the day, demonic possession, or just encephalitis not yet diagnosed. Management of patients with this complex and rare disease requires multidisciplinary involvement, and while there is still so much unknown, new treatments are on the horizon, including a promising medication called bortezomib for an anti-NMDA. They found it was successful in treating another kind of cancer, a plasmacytoma cancer, and they think it's really looks good at treating anti-NMDA. Excellent nursing care is required for these patients, for their behavioral management, for safe medication administration, providing for their physical needs, prevention of complications, vigilance for those emerging autonomic instability issues, and patient and family support, all the way from the acute phase all the way to rehabilitation. Here are my references, and like I said, if you enjoyed, please shoot me back a quick email and let me know what you thought. Thanks very much.